Thank you. Again, welcome everyone. My name is Kasey Petika. I'm glad you have joined us for today's session, which will focus on pain assessment. We're going to explore why pain is such a critical area for improvement within emergency departments and why it's often overlooked despite being the #1 reason kids seek emergency care. We'll also walk through the tools and strategies available through the National Pediatric Readiness Quality Initiative, or NPRQI, data platform that supports EDs in measuring performance, identifying gaps, and making targeted improvements. By the end of today's session, you'll leave with both the rationale and the roadmap to begin improving pain assessment in your ED. We would like to acknowledge that the Emergency Medical Services for Children Innovation and Improvement Center is funded through a cooperative agreement with the Health Resources and Services Administration, which is within the U.S. Department of Health and Human Services. Additionally, NPRQI is also supported by the Toyota Way Forward Fund. The contents of today's presentation are those of the authors and do not necessarily represent the official views of nor an endorsement by HRSA, HHS, or the U.S. government. A few quick housekeeping notes before we get started with today's session. Please note that we want this to be a safe, supportive space. We encourage open dialogue, sharing successes and challenges while asking questions. To keep us organized, please add your questions to the chat feature at any time. We'll pause along the way and save time at the end for questions. For those looking to receive continuing education credit, please add your first and last name, if you've not already, to the chat and complete the survey after today's session. Now, today we are joined by Dr. Chumpitazi, who is the Chief of Pediatric Emergency Medicine and a Professor of Pediatrics at Duke University School of Medicine. She will help us explore why we should begin improving the assessment of pain. But before we begin discussing the importance of pain assessment and the ways in which we can improve our performance in this area, let's first review the importance of pediatric readiness. So here's a surprising fact. 85% of children who need emergency care are treated in general emergency departments, not in pediatric-specific facilities. This means most kids who come in with serious injuries or illnesses are seen in hospitals that primarily serve adults. So what does this mean? It means that general EDs need to be prepared to care for children effectively. Here's the challenge. Many emergency departments see very few pediatric patients. When pediatric patient volumes are low, it's harder to prioritize pediatric-specific training, equipment, and systems, as staff may not encounter pediatric cases often enough to maintain confidence and skills. This creates a gap, because when a critically ill child does arrive, the team needs to be ready. Improving pediatric readiness relies on understanding current gaps, and this is where quality improvement comes in. Pediatric readiness means having the people, processes, and resources in place to provide high-quality care. The goal is simple. Every child should receive safe, timely, and effective care no matter where they show up. Because pediatric readiness isn't just a checklist, it's a commitment to quality care. And what we know is that quality improvement plans are a key driver in improving pediatric readiness. One of the foundations of quality improvement is that you can't improve what you don't measure. Quality improvement is a systematic, continuous action that leads to measurable improvements in care. It's central to pediatric readiness and is associated with better outcomes for children. Yet, in the 2020 National Pediatric Readiness Project Assessment, only 50% of EDs reported involving pediatrics in their QI processes, and only 1/3 of those were tracking pediatric-specific metrics. That's a major opportunity for improvement. EDs who do include pediatrics in quality improvement efforts see a 25-point increase in their adjusted pediatric readiness score. Having a higher pediatric readiness score is linked to improved outcomes with a potential of 2,000 pediatric lives that could be saved annually. And the National Pediatric Readiness Project Assessment helps EDs identify gaps in their pediatric systems of care. You can measure your ED's pediatric score during the 2026 NPRP assessment launching in March. NPRQI also complements that by providing the tools needed to address those gaps and monitor improvements. Using the 28 nationally recognized pediatric quality measures that include the percent of pediatric patients with pain assessed. So with that, I will hand things over to Dr. Chumpitazi to help us get started with improving pediatric pain assessment.
Well, I'd like to add my welcome to the one you've heard from Kasey today. I am just so excited to have you here and to work with you on these different measures while you work to improve pediatric readiness in your hospitals and systems and your regions. I really just want to start with the fact that pain is that number one reason that patients present to the ED. And so, next slide, Kasey. We know that a lot of those presentations are the worst days in the lives of these parents and families. So they might have gotten that call that they fell off the monkey bars or the playground equipment, or in the light of the New England storms, the sledding accident, or next picture, have had a laceration or something that needs attention. So when we talk about pain, it can be a variety of reasons, from things that would benefit from a variety of modalities. And so the first way we need to start with getting to the bottom of that pain is by the assessment. So next slide, please. So pain assessment can be both that diagnostic indicator as well as then the therapeutic tracker of that pain. And so it can guide that patient evaluation and support an accurate diagnosis. So when that patient is moving very slowly, grabbing the right lower quadrant and gently getting themselves on that bed, you might start to have indication that, hey, maybe it's the appendicitis or the appendix, and what we might do about that. But we want to see what is that patient's pain. It can also use that to guide that symptom. So as we give that treatment for the broken arm, might add that immobilization or the ice. How are we improving pain during those times? Putting on some topical numbing medicine. How quick are we to do that? And how do we use that assessment to guide our treatment decisions? So not only just that decision, but then how are we doing with that pain, and how are we going to improve from the initial baseline? And so there's a variety of tools that we'll go through. One is shown here with the stoplight tool, and we'll have an opportunity to dive more into those assessments in a minute. But next slide. So as Kasey mentioned, it's the number one reason that patients come to seek emergency care, and 80% of pediatric visits have some degree of pain. And so kids are less likely to get pain medications than their adult counterparts in study after study, and different proportions seem to receive pain medications differently. And that's across the EMS system as well. And so how can we do a better job of a consistent approach to that pain assessment? Next slide, please. So we know that unrecognized pain can lead to delayed or inadequate treatment. So if a stoic individual is not letting the team know about their pain, they may have delay in care. And then kids express pain differently. A lot of the times there's an anxiety component, as well as just that emotional and psychosocial aspects. And so we need to try to think about how are we doing that at the right developmental level, and then with chronic disease and developmental delay as well, being able to use pain scores that can adequately represent and translate how we're doing with that improved pain. In addition, emotional distress and fear can interact and make that pain assessment difficult as well. Next slide. So how might we improve in our system? So as you think about your ED, and as I've been so grateful to hear from the methods that you all have used in the previous aspects of this, the collaboratives, we can look for different ways and how might we improve. If it's a problem with that initial just number assessment, that we're not hitting that assessment on every patient, what is keeping us from doing that or keeping us from the documentation of that? And then how do we then remove barriers to get that pain treated, and then and then ultimately managed and get that throughput. So there's lots of different aspects of each area of the pain management that we might dive into to think about for this metric. Next slide, please.
Thank you, Corrie. So now that we have looked at why pain is such a critical area for improvement within emergency departments, let's now talk about how quality improvement helps to operationalize improvement in pediatric pain assessment and some of the tools that are available to you. One such tool is NPRQI, the National Pediatric Readiness Quality Initiative. This is a free, self-paced quality improvement data platform that's designed for emergency departments. What it does is help EDs measure, benchmark, and improve their performance on key pediatric processes in a secure way. One of the biggest benefits is that it gives hospitals a clear framework for continuous quality improvement. That's essential for improving pediatric readiness and making sure kids get the best possible care. Ultimately, NPRQI is designed to inform and empower frontline staff so they have insights and tools to make real improvements. NPRQI transforms data into meaningful improvement using a simple structure of measure, reflect, and improve. You can easily capture data, track trends, share results with your team. Pain assessment is one of the areas where this data can help drive change. As Dr. Chumpitazi shared, nearly 80% of pediatric ED visits involve pain, and wide variations in practices across those EDs. NPRQI is especially valuable when it comes to measuring pain assessment because it provides standardized pediatric quality measures, offering you the ability to see real-time data for rapid test of change, national benchmarking, cohort benchmarking, and a place to track your interventions and see impact over time. NPRQI provides 28 quality measures that were developed with input from 25 plus professional organizations and experts. They were designed to help improve pediatric outcomes in common conditions. Here we're highlighting the quality measures that fall under assessment, the percentage of pediatric patients with pain assessed, as well as the ED length of stay and the median time from triage to first intervention. Based on your ED's data, you'll be able to view your performance and easily turn it into actionable insights using the dashboard and reports feature. Here's an example of one of those dashboards. This is the graphical view, which allows you to monitor trends, track progress, and even share this graph with your team and leadership. Now, for those sites who may already be performing well on the percentage of pediatric patients with pain assessed, we are excited to share the addition of our advanced measures. These reports will help sites view their performance on the percentage of pediatric patients with pain reassessed, the percentage of pediatric patients with moderate to severe pain who received an analgesic, the median time from triage to analgesic for patients with moderate to severe pain, and the percentage of pediatric patients with pain reassessed who had a reduction in pain score. We look forward to sharing additional information as these reports become available, but hope these advanced measures support you all in your efforts to continue improving the assessment and management of pediatric pain. I'm going to hand things back over to Corrie. Oh, you're on mute, Corrie. Corrie.
Yeah, thanks.
Yep.
We are really trying to think about why these pain measures matter. And so we know that the high throughput EDs, we need to make decisions real time and quickly. And there's wide variation in practice a lot of the times. The workforce has been challenging, and how do we continue to onboard new staff throughout the system, but especially in the ED? And then how might we be able to standardize that care so we eliminate unnecessary risk as well as ensure the same quality process for all of our patients. So NPR provides that structure to track and improve these measures in a way that is easy to interact with. And going through this collaborative, you have a team of support behind you. So it's your own cheerleaders and such great innovations that folks come up with throughout the collaborative. So as we think back to that case from the beginning of the child falling off that slide, we can think of a variety of things. A lot of the times technology does pose a challenge and opportunity in our tools for how do we capture those wins as far as consistent high levels of pain assessment. But How might those advanced measures too? How might that time to splinting, time to pain medication before X-ray, as we think through like this case and example. So with that, I'll take a quick look on the next slide at a few of the pain assessment tools that have been used throughout different EDs and may be used in your ED, but the FLAC score in younger infants and has been validated in developmental delay children as well. And then the FACES revised pain scale, as well as then a verbal numerical rating scale where the patient can verbally tell you a number. So there's a variety of tools through pain assessment that we'll be able to chat about and use the ones that are right for you and your system. But that's just one aspect of the variability and that we have seen in this metric. So let's talk about how do we improve that pain assessment, Kasey?
Yeah, let's go ahead and put this into practice by walking through a process of reviewing your baseline performance, setting an aim, and considering some strategies for improvement. So if you're just getting started with improving pediatric pain assessment, we recommend reviewing 30 charts to establish your baseline. Having at least 3 data points will give you a more reliable average before you begin testing changes. After you've entered your charts, you may find that your baseline performance is 54% of pediatric patients with their pain assessed. When we start talking about improving any process, including pain assessment, we need a clear target to work towards. That's where SMART aim comes in. A SMART aim gives your team a shared, specific goal that's measurable and time-bound, so everyone understands what you're trying to improve and how you'll know if you succeeded. SMART aims help teams stay focused by avoiding vague intentions like do better and ensure that the changes you test are tied to an outcome that you can actually track. They also make it easier to communicate your goals across your ED and monitor your progress over time. You can use this template by implementing an intervention will improve a process or practice, resulting in a measurable metric by a target date. Here's what a SMART aim might sound like when we put it into practice. By updating triage posters with an age-appropriate pain scale, we'll improve the percentage of pediatric patients with pain assessed, resulting in a 10% increase by December of 2026. July of 2026. Notice how it clearly states the intervention, the measure we want to improve, the measurable outcome, and the deadline. This level of clarity helps your team stay aligned and focused. It gives you something concrete to track. Now that we've established a clear SMART aim, the next step is deciding how we're going to reach it. That's where a change strategy comes in. Change strategies are the intentional adjustments we make to our workflows, communication, tools, or environment that help remove barriers and make the desired behavior, like consistent pain assessment, easier and more reliable for staff. These strategies aren't random ideas. They're targeted action informed by your baseline data, your SMART aim, and the real-world challenges your team experiences every day. The goal is to choose a small, practical change that you can test quickly, learn from, and refine through a PDSA cycle or a plan, do, study, act cycle. And in the next few slides, Dr. Chumpitazi will walk through some examples of change strategies that we've seen from past participants and the successes that they have seen when improving pediatric pain assessment in their ED.
Yeah, so as I mentioned, really great projects from former participants. And so you might start with targeted staff training. It might be the triage nurses that really need to target and do huddles at shift change, or it might be triaging back in the room when we're in a pull to full model as some of your institutions do, in which case the bedside nurses in your area might be that targeted group. But think about what is the best way to get that information. Email is great, but a lot of the times there's some other trainings that are helpful. And then as far as how do we make a difference consistently across the groups, we might be able to provide some one-on-one feedback. So with that data entered, might be able to follow up with some of those staff members that are consistently missing the pain scores. And sometimes you may learn a variety of things, including the fact that they document in a different place or have a different process. And so you're able to really make that change on a one-on-one basis, and that can be very effective, as can sometimes incentives. So the shift that has the most pain assessment might get a treat or something. There's a variety of those kind of things we can do to target that individual or those teams. And then moving on to other strategies that sometimes are helpful, those visual reminders. A lot of the times there's bedside care boards that have that pain assessment on it, or badge buddies that you're able to use to consistently make it easier for those to use the age appropriate scales to get that pain assessment done. Flyers and education around the bathroom is a big place for in the employee restroom for putting up different flyers or keeping track of your wins that they can see those and be engaged in those. And then huddles, so shift change and opportunities to be able to verbally provide that feedback as well are all ways to think about improving that pain number. Next slide. Yep. And then the technology innovations are great, but sometimes a little bit more challenging to different institutions, but not for some. So EMR hard stop for pain assessment or time limits within the pain medication administration are great ways that different institutions have been able to get that pain assessment done consistently. And then integrating that pain scale into that EMR before an additional medication is given are ways that folks have been able to improve that pain assessment. Next slide. So then now that we've reviewed that PDSA cycle, we have a starting baseline of 54% as that example. We put it into the plan, do, study, act model. And so we were able to plan that we know that we have 54% of patients with pain assessed. And we want to pick one of those strategies to improve and then measure that compliance. That's the study or the intervention we're going to try to do to increase that score to 65%. We wanted about a 10% increase. And then we're going to refine that workflow. We're going to monitor it at set intervals and try to make those improvements. So I'd like to open it up to see what strategies has your teams used to improve pain assessment? If you've done that in the past, I see a couple pros in that area. Otherwise, type it in the chat if you'd like to. But what other things have you done to improve your pain assessment? Folks can come off mute if you'd like. Great. We have one comment in the chat about using the revised plaque, which can be fantastic addition to the pain scores, because sometimes if you're just using numeric scores or folks are used to just using those FACES or self-report, you really need a scale available and that folks are trained on to be able to make that assessment in other age groups and developmental status. Yeah, wonderful. Really just that manager report out of those scores. That was one of the opportunities for us too. We were using just a tracer for an accreditation that was upcoming, and they were saying that we were doing a 90% job of our pain reassessment. And I thought that's a little too high for us as patients are off to radiology or the units. And so, what is the true answer? And we we learned that it was really much lower once we got an accurate reporting tool. So that's good. I see some EMR opportunities in the past in the text too. I don't know, Kasey, if you want to call any of those that are standing. They're moving quickly.
Yeah, timed reminders that folks are using on their EMR. Kate had also mentioned standing orders and triage for analgesia administration in cases of moderate to severe pain. Someone else put in PD triage chart audits monthly that are sent out.
Yeah, and thank you, Megan, for that comment too, because standing orders can be very hospital specific and are always a source of debate. And so throughout the collaborative, we'll be able to share different resources on the website that we're going to run through at the end of this talk and provide different examples as well. So we can help you out with that, bookmarking that comment.
I saw the update to the EMR with timed reminders for reassessment after treating pain.
Yeah, that's great. And if you're using electronic scanning too, being able to add that to your different device or rover for an alarm 30 minutes after your IV medication that you might do a pain assessment. There's different technologies that we've had teams use that can really help with this. Wonderful. I love it. Already generating fabulous ideas for your PDSA cycle statement. Would anybody like to, who's done it in the past and has been working on it, or who's thinking about this, verbalize their aim?
Totally all right if you're not there yet, if you're just joining today to sort of learn more about this area of focus and see if this might be where you want to focus your intentions for your quality improvement work. But exciting to see a lot of good work already happening.
Sorry, I was chewing. This is Jasmine. I'm at Ascension Seton Southwest at Austin, Texas. So I was at Dell Children's and I was new to Seton Southwest ER, and I took on the PEC role over there last 2024. So I did do a PDSA as part of my career portfolio, and that one really helped as far as just getting everybody to pay attention as far as their triage, and then collecting the data and how we can improve. And I collected the baseline as far as how well everybody was doing, if they even knew as far as even like the pain, vitals, collecting all the vitals, and the Humpty Dumpty and the fall risks. And I think even we started doing kind of diffuse. And so there's a lot of improvement and everybody started participating. And so we're continuing to do that. I don't have the charts with me right now, but there was improvement. I could give you better percentage if I had it in front of me.
Yeah, that's awesome, Jasmine. Really great work. And I think I hear just the excitement in your voice, and I'm sure you generated in your team too as you start to improve. I just love that.
Corey, there was also a comment about someone said that they have orders for Motrin and Tylenol just for basic pain until they can be assessed by a provider. And then if the patient is in a room where they can be monitored, they use standing orders for acute injury that could potentially include intranasal fentanyl.
I love that. Intranasal fentanyl or intranasal adjuncts in general are usually a good at part of your armamentarium for pain and sedation. And so intranasal fentanyl for our sickle cell patients has been a big adjunct too while we're waiting for our vascular access team challenges with difficult access. And so integrating PDSA advanced measures around that is really great. And then a comment we had heard on one of our last collaboratives is there's a couple studies in the works. One is out of our adult population here at Duke, but then there's another out of the Midwest looking at that intranasal fentanyl monitoring. And so it's actually thousands and thousands of charts, very safe to give that dose without having them on monitoring. And so that's another thing that we talk through in this collaborative, but we'll have an opportunity to share some of that data. Ooh, and I love that. The topical adjuncts are always really great measures to try to introduce. I know a lot of institutions now are switching to some of those different ethyl chloride sprays as well, and different brand names. And so how might the rollout of those procedures increase access for topical pain management for both IV starts as well as then for laceration repairs. And so those are great modalities. We're doing a study like that right now with our JTIP, trying to get that used, and we've just keep on hitting some pharmacy barriers there. But there's a lot of really great examples. So I love this. Lots of thinking, and really excited to see where these teams are going to go with these pain metrics.
Corey, there was a question in there about, is there an age limit on any of the triage orders?
That is state, and then Dr. Remick might be able to answer that too, but that a lot of the times is institutional specific, more so even than state and regulatory.
Yeah, I mean it's dependent on the medication and the situation, but yes, there are lower age limits, and it's probably going to be based on what your institution is comfortable with.
Thank you.
Well, as so many of you are already doing some great work in your EDs to implement change and to see improvement, we have a couple tools available to you to help you monitor your progress through the NPRQI platform. Again, you have that graphical view where you'll be able to monitor your progress over time. It's a great way to sort of indicate, we implemented a new stop in our EMR where pain had to be reassessed or where pain had to be assessed. And you might indicate that happened in Q1 of this year. And from that point forward, you see an improvement in your performance on your graph. So it's a great tool to have a visual representation of the work you're doing. There's also ability to sort of track or log the types of interventions that you're implementing and the date of your intervention. So that'll really help you refer back to your PDSA cycles and sort of see, well, we started with education and we then advance to adding some reminders in triage or badge buddies. And then maybe ultimately you're working towards adding some of those EMR updates into your system. So it's just some ways to help you monitor your work and help you showcase the great work that you're already doing and match that to your performance data. So we're excited to be able to share those resources with you through the NPRQI platform. And share with you that, this is a continual process. You'll continue to revise your plans, monitor your progress, change your implementations, by adding new change strategies or developing them, inviting new people to take part in it, spreading it across your institution, and then always, going back to your SMART aim and revising it as you continue to make progress, making sure that it's relevant and attainable to your team so that you can really showcase your progress and get them excited about this work and celebrate your successes. So I think those are some of the next steps to consider as you begin this process of improving your assessment of pediatric pain.
And I really love one other comment I see in the chat is we have the discharge vital signs. A lot of institutions want to have that full set of vitals before patients are discharged. A lot of the times, the heart rate's 200 with fever and those kind of things, but pain is not on there. And I think that was a really great idea, as well as thinking about a process on the discharge end too, where we think about assessment on the front end, but what are those discharge scores? And taking a look at patients discharged with abdominal pain and gastro that come back as appendicitis and those kind of things, that would be a great opportunity as well. So thank you for adding that on the discharge side as well.
Yeah, that's great too, because we have some more time here for some questions. So we have a number of folks on the call with us today. We have Dr. Chumpitazi, Dr. Kate Remick. We have some members of the NPRQI team, and we have Robin Goodman with us as well. So lots of members of the EMSC NPRQI team on, and we would love to help address your questions or help you think through some ideas as you begin considering selecting pain as your area of focus.
And I would say a reminder that dialing into this call doesn't necessitate you having choose pain as your area of emphasis. I think it's a great one to choose, but if there's other things that your team wants to do, but I think this is really an awesome opportunity for thinking through pain as a metric, and we're going to be able to show some resources and walk through some things in a minute, but I want to make sure we have that time to answer your questions.
We have a question for you.
I see that intranasal question too. So talking about it safely in unmonitored areas. There's been a study done quite some time ago, so I keep looking for it in publication. I'm gonna look for that while you do, if it's out in press. But we did too in our adults. I think 3,600 patients and had no episodes of desaturation or any adverse events in giving it in that population as well. So but it's definitely an evolving area of interest, and more to come on that.
Thank you, Gregory, for your question. If you would like, you can come off mute and share your questions, or you can add them in the chat.
Another concern I always have while you're thinking about those is just the use of non-weight-based medication and pain meds in kids, and taking those transfer calls and seeing some on both ends, either large opioid doses or not enough pain. I think that's another area for improvement for some EDs and EDs that are embedded in adult systems as well. I don't know if your teams have had thoughts on how to improve that.
Kasey, I think there might have been a question about access to the NPRQI platform. I wasn't seeing that in my feed. I guess I had overlooked it, but we know that folks are very eager to get access to the NPRQI platform. And so we are working to get folks access in the next week. We appreciate your patience as we are doing rolled out implementation.
Thank you for that update, Lisa. I also have a comment from Lisa in the chat. They have standing orders for Tylenol and Motrin for fever and pain and triage, weight-based, as well as sheets to hand out for discharge for fever patients. Great strategies there.
Show of hands, how many are using NUM spray for their IV starts? Oh, good. Great. How do you like it?
We have a thumbs down in the chat.
And a few pay needs options. Great. And as we know with any adjunct, you know, a lot of the times patient specific and provider preference as well. And then that's another really great point. Megan is thinking about Buzzy, and having access to Buzzy just does amazing things. And for digital blocks, it's fantastic for just digital blocks as well, and getting in, having that in for that as well, and access hours that child life specialists might not be available if they're available at your institution.
I have a comment about how it could be difficult to define a normal versus abnormal value for pain.
Wonderful. And there's a lot of data on the pain science, and without getting too much into the psychometrics of the scoring, a lot of the times that's why I really love that stoplight scale that we showed at the beginning as a scale that our Canadian and US pain researchers have been using, because it lets you know green, I'm good, I don't need anything right now. Yellow, I'm doing okay, but check back with me. And then red is, hey, I'm in pain, I need something now. So it translates those scales to an actionable deliverable as far as needing medication. And then based on your hospital's institutional policy, sometimes they recommend different medications specifically for different numbers of pain. And as we know, different populations of folks may have a different pain. One of my areas of interest is sickle cell, and sometimes, you know, the patient may never be less than a 9 out of 10, and they're feeling fine, and they're going home because they're not a 10. And so I think there's always some leeway in that, and then just thinking about your hospital policy and what makes sense to, and sometimes to directly in the orders as far as which medications to try for which pain medications.
Corey, there was a question in the chat about getting examples of pain medication orders. If folks are able to share any of that information, or if you have any kind of go-to examples.
Yeah, absolutely. And actually, Kasey, we can move on to some of those resources. We did pain management as a toolkit for the pediatric education and advocacy kits for the EIIC. And so we developed a bunch of resources with our Canadian counterparts. So the TREC, Translating Research and Education and Kids across Canada, is worked with us on these statements. And so we have a medication dosing, and we have some resources on there that have been developed. That first one under the card in the purple on the left side of your screen is developed in partnership with some of our grants to the state partnership program in Florida, where they have some virtual reality tools in that toolkit. There's a bunch of the Skip Kids is the has really great videos and cartoons for different needle phobia and situations. And then that QR code will give you access directly to that pain toolkit. I actually love the in the seizure toolkit is a video done by Dr. Julia Magana, that looks at the intranasal medications and kind of has a child touching the atomizer and thinking about what they think about that in regards to midazolam for seizures. But it's a really great additional resource that that we can use. So this is just one aspect of that toolkit. And then as far as the specific pathways and things, we'll show you access to the, why don't we walk through, Kasey, the, or Lisa, the resources for this pain metric, and we can kind of give them a lay of the land and where some of these things lie. I think it's the next slide.
Yeah, there's a link to the resources for the collaborative and also for the focus area for pain. I'll repost those for folks that maybe joined a little bit late.
Thank you for sharing some about the peak with everyone, Corrie. We do have a number of other resources available to support you all in this work, including our intervention bundles, helped put together by Corrie. This is a great tool for those who are looking to implement improvement in this area. It provides an overview of the topic as well as some of those change strategies we've been discussing. We also have our collaborative hub where EMSC NPRQI collaborative participants can go and find updates and helpful information. This is also where you can sign up for office hours. In addition to the NPRQI website, which is the central point for all things NPRQI, and for those who are looking forward to utilizing the upgraded platform, as Lisa mentioned earlier, we anticipate granting you all access within the week. So we're excited to get that to you all.
And thank you so much, Lisa, for putting those in the chat. So there's that access to that pain intervention bundle, as well as some of those EMSC collaborative resources. And then there's additional opportunities that Lisa is going to tell you about.
So we have additional opportunities to connect through our monthly collaborative sessions. They are held on the third Tuesday of each month at 11 a.m. Central, starting in March. And then we also offer those one-on-one support meetings. They're 20 minutes with members of the EMSC NPRQI team, as well as some experts from the NPRQI group. So we can help address your questions. You can access that registration through the collaborative hub. If you need help getting your password set up for that, please reach out to us by email. We can help you with that.
Oh, and I love that nitrous is coming up in the chat. I am a huge, huge fan of nitrous oxide. And we set up a protocol when I was at Texas Children's where we had nurse administered nitrous if it was the 50-50 mix. And so that was hugely successful. I agree with you that the credentialing pathways can sometimes be cumbersome in access. And then lately it's been the environmental concerns seem to be shutting down some programs as well. But it is a just fantastic adjunct, and I really love it for difficult access patients as well, because it's a vasodilator. So it's just been wonderful for my patients with sickle cell disease as well. So I don't know if anybody else wants to unmute and talk a little bit about nitrous. I definitely find it more helpful for that moderate to minimal painful procedures, still significant painful procedures, but in resource constrained settings, for like even for a fracture that then is having such bad nerve pain because of that dislocation, and being able to use the nitrous in addition with topical adjuncts and some lidocaine is really helpful. So that is great. And then different EMS agencies as well have it on their trucks. So Montgomery County and outside of Houston does have nitrous in their ambulance system. And so there are some EMS systems as well that use nitrous. And then we did have a question about JTIP. JTIP is that jet lidocaine, and thank you for providing that video of that. A lot of places really love JTIP. I don't know if anybody who uses it regularly for their IV starts. You can get it from the company as the product, or your pharmacy sometimes can compound it with the trigger. It has a little bit of a pop when it goes in, but then it pushes that lidocaine in, and folks have really loved that. Has anybody on the call used that wants to comment? There's several large institutions, children's in Dallas, Wisconsin, many places that really like it. Oh, awesome. Brittany has them, loves them. Yeah, it's one of the things we're really trying to roll out in our ED currently and then across the system. Another adjunct. So really amazing opportunities to think about additional adjuncts you have to make a dent for pain management in children in your EDs. And so I really welcome you all to join the pain bundle and metric and working with you through these. And I always learn so much from all of you. And so continue to keep these great things coming as we get the toolkit open. Definitely can welcome your resources too. So if you have some top quality resources that you think we should include, definitely we have a mechanism to do that.
Yeah, we are excited to help you all create a library of your resources to share with one another. So if you have a resource related to pain assessment or pain management that you would like to share with the group, we have that library available in the collaborative hub. Excited to see
Yeah, and we really we haven't looked at pain. There's a question about child life specialists. Child life specialists are amazing. They've changed my practice, and I really just love their ability to guide patients through at their right developmental and um, receptiveness level, depending on the degree of their pain and anxiety. Where we really have seen a huge benefit is in our sedation unit. And so we have one particular child life specialist, and he has really decreased our need for sedation, actually. So he's able to talk the patients through their MRIs in a way we hadn't been able to do before. And so child life specialists are amazing, and we've integrated their comments and tools and tips into our talks and presentations as well.
I think also if you're, building your quality improvement team at your site and you have a child's life specialist in your ED or at your hospital, I think they're a great person to invite to be a part of your quality improvement work, bringing
Yeah, I
their
really can't.
expertise.
Yep, yep. I can't highlight enough the biggest bang and sustainable impact will be made, I believe, by multidisciplinary teams. So getting it, and it might be your tech in the area who a lot of the times has to hold for painful procedures, or the child life specialist or the pharmacist and getting things integrated, or your Epic guru or link to your EMR, electronic medical record. So having a team around this really does help amplify the work. And you'll don't maybe need one at the outset, but as you refine your questions, you'll be able to develop that bench of folks that are going to really help make the impact by being able to introduce the measures that are going to be make the improved change strategy met, and then also that make it sustainable.
If you still have any questions, feel free to put them in the chat. I'm just going to share with you some other opportunities to learn about our other areas of focus. And so our upcoming focus area sessions, next week we'll have a session on abnormal vital sign reassessment. Then the following week, our session on head trauma. And then the beginning of March, we'll have a session on suicide assessment and management. So again, these are our 4 areas of focus, which we'll be providing support in over the course of the EMSC NPRQI collaborative. So if you're still interested in learning more about each of these areas of focus, we invite you to join us. If you're unable to attend the sessions, they will be recorded and made available on our collaborative sessions page.
And Kasey, if somebody has a question about wanting to enter data on all of them, but maybe just participating in one aspect of that, that's possible, right?
Yes. I don't know if Lisa or Sonia would like to sort of talk a bit about how data entry works in NPRQI.
Yeah, data entry is really takes a holistic approach. So it really looks at all 4 phases of care. So you will be providing data on a variety of aspects of that pediatric patient's visit at the ED. You can enter data for multiple focus areas, but we do suggest that for the collaborative, if you're just starting out with your quality improvement work, that you focus on one specific area first, just to kind of get your footing and your grounding with all of the work that's involved with it. And then as you gain more experience and confidence, you can continue to add additional focus areas if you feel there's a need for that.
Elisa?
And I'll just add one more comment, which is that you may find that in the beginning, when you're entering your baseline data and looking at performance, you'll be able to see your performance on all of these bundles. So if you're not quite sure what you want to work on yet, then you can, look at encounters more broadly. That includes head trauma, suicide, et cetera, and then begin to look at how you're performing to help make that decision. So, there's a lot of flexibility in the platform.
And I really love that if you start out asking one question and maybe thinking about one change strategy, and in your developing your team and understanding what the barriers and opportunities are, you want to switch. That's perfectly fine as well. And getting on board with that. So it's definitely a fluid process, and you learn so much from the teams throughout the collaborative.
Thank you all. I know we're close to the top of the hour, so I did want to put up our continuing education information for you. Again, if you have not put your first and last name in the chat, here's your reminder to do so. And then we'll ask that you complete this survey so that you may receive your continuing education credit. And I saw another question in the chat about your site's access to NPRQI. If you wouldn't mind adding your site name, and then we can follow up with you after today's session.
Yep, and I will say the team is fantastic. If you're having questions or about the POA, reach out to that website, just the NPRQI at austin.utexas.edu, and they can really help walk you through, or get the people who need to talk to the people if you're not very technologically advanced like I am not. Well, thank you so much for joining today. We were really excited to talk about this collaborative, and look forward to working with you throughout this collaborative. And I'll turn it back to Kasey for final word.
Yes. Thank you, Corrie, and thank you all for joining today's session. Again, if you are interested in hearing more about our other areas of focus, we look forward to seeing you at our future sessions. Have a great rest of your day.